So just so we can get to know each other, just like we usually do, if you guys can put your name and your title and in which organization or clinic you're from in the chat, that'd be really helpful. So thank you if you've already done that, and if not, you guys can just go ahead and start putting that information in there. So first, let me review today's agenda. So we, as always, start with introductions. Then we have a 15-minute didactic presentation by Dr. Sahar. Then we have a case presentation from Missouri from Alicia, Nuhu, and Sholay. And then we go into our Q&A session, and then we have some case recommendations. Next, please. So the Project ECHO stands for Moving Knowledge Instead of People. The acronym stands for Extension for Community Health Outcomes. Next slide, please. Just some overall reminders. These sessions will be recorded, and we do have some data collection for the purpose of quality improvement. So please don't mention any patient health information in the discussion, since these are recorded. Next slide, please. Yeah, next slide, please. Just some general Zoom reminders, as always. Just keep your mic muted, please, if you're not talking, but when you're speaking, please do unmute your mic. If you have any questions, ask the questions into the chat box, or you can raise your hand and we'll call on you. We do encourage questions. We have some really interesting case presenters, and so I know that they're here to help you guys understand their area of expertise, and so we do highly encourage questions in the chat box or by raising your hand. Next, or if you have any questions, or if you have any technical issues, you can do a direct chat to Brenda or Chris, and they'll help you through those. This is just a disclosure from CDC. They're saying that none of our people have financial relationship with ineligible companies. Next slide, please. All right, so this is our speakers. So this is a brief introduction. Dr. Liora Sahar is the Senior Director for Data Science at the American Cancer Society. She provides leadership, expertise, and operational support as it relates to the integration of geospatial systems and science within the organizational projects and research. Beyond her professional roles, she has a great passion for teaching and mentoring. She's a Girl Scout troop leader, and she's been teaching GIS and remote sensing classes at the Georgia Institute of Technology, while engaging with her local community, providing STEM and GIS sessions at local schools. She's also joined here with her daughter, Victoria Sahar. She's one of our superstar medical students at the Medical College of Georgia. She's applying to general surgery this year, and she has an interest in population health, and so they'll be tag teaming this presentation. So Dr. Sahar, you can go ahead and take it away.
Thank you so much. And thank you for extending the invitation to come. So yeah, I am a very proud MCG mom, and happy to be here today. So do you see my screen?
Mm-hmm.
Okay.
We do.
So wonderful. So especially for, let me see how I can get this one to get smaller. I don't know. Okay, especially for colorectal cancer audience, what is GI, right? So in my world, GI stands for geographic information, and then it's either systems, science, some would say services. My team will call the Geospatial Solutions team because we do everything, so we decided to add the additional S, but we both engage in research and then provide tools and applications to be able to inform decision-making at different levels of the organizations and with our partners. So the role of GIS is really to answer the question of where. So where is the cancer mortality rate, incidence rate? Where are our team members and our volunteers at the American Cancer Society? Where are those constituents and people, right, that we would like to reach? And where are the health systems and our partners? So it's really all about location, location, location. And I love the pyramid at the top right over there that shows us the data, information, knowledge. Most of you are familiar with that. And then there is the wisdom. Are we there? Probably not, but we can always, try to get to organizational wisdom. So that is part of what my team is doing. And when we're talking about decision-making and what is the real power of GIS, so the maps are, you know, if they are cartographically sound and well designed, they're beautiful, they're very appealing. But the power of GIS is really in the attributes. We have a database in the background, and what we do is with GIS we're able to find those relationships in space, right? So we are able to take the data and tell some kind of a story. When you look at the map, there is a story associated with that. We also have a new technology called story maps. I'm going to talk briefly about that in a second, but really it's all about taking actions. And I'm not going to go into too much of that. I want to share with you that specific visualization that just happened today. At the beginning of the day, I had a meeting with my colleagues in California, and what you see is a snapshot of a dashboard that has 4 different maps. They're all interactive, so you click on things and pop-ups shows up and everything. But when we are talking about identifying gaps and opportunities, right, and identifying those target areas, when you look at this area, this is in San Diego, you start to see, okay, here we have the social vulnerability index from the CDC. Here we have income and poverty. Here we have race and ethnicity, and here we have education. When you bring data together in that sense, different patterns and trends starts to emerge, right? And this is really what GIS is all about. So what I'm going to talk to you today a little bit about is, you know, we started working this year very extensively with the National Colorectal Cancer as well. But for the past couple of years, we had quite a lot of collaboration with the National Lung Cancer Roundtable. And we worked at the national level. We worked with state roundtables. We worked with researchers across the nation. And we work internally with the ACS. And I'm going to show you how GIS was very effective at all of those different levels. So I took this specific slide. Those of you that attended the Georgia Colorectal Cancer Roundtable meeting earlier this year, I really like this slide because, and this is from Dr. Bob Smith, who is the Senior VP of Cancer Screening at the American Cancer Society. And he said, okay, how can state roundtables make a difference? And think not just about state, it can be a region, it can be national, but it's all about knowing your state, right? So look at the demographics, understand the demographics, have a description of the epidemiology of colorectal cancer. Let's talk about access to care, and that can be access to screening, access to treatment, access to clinical trial, right? All of those. What are the barriers to care? And really, GIS can help you with all of those. It can be the beginning, and then it can be the research that will take you to the next level to understand the gaps. And then eventually we will be able to create those interactive and easy to explore map and apps and tools. Now, GIS is very effective, and I'm going to give you a couple of examples in identifying patterns and trends. I'm going to show you some of examples from the past. And then, of course, by just the nature of the data, the idea of access and geographic access. I'm not talking about other components of other aspects of access, but specifically for proximity, GIS is very effective in looking into that. So let's look at a recent project that we published about that was all about access to lung cancer screening. So you have to start with where screening is taking place, right? So we started with screening locations, and this is how screening, the result of the analysis. By the way, the analysis was done at the census tract level, and then we aggregated. And in this case, you see the results at the state level. And I'm going to talk about a very important aspect in GIS, which is what is your scale of analysis and what is the scale of presentation? What do you need actually to be able to go and plan strategies and interventions in the community? So at the state level, the darker red, the more access people have, and the yellow is full access in the entire state. This is how it looks like at the county level. It's almost like there is a line in the middle of the country where there is more access to the east, right, and less access to the west, with a couple of notable pockets, you know, across the east. Now, what we did then is we brought together access, and in this case, smoking. So for example, this is a bivariate map. So we brought in 2 different variables. So for example, the really dark brown areas are those areas where we have higher number of estimated people aged 55 to 79 that don't have access to lung cancer screening. And there is also a high percentage of adult who smoke, okay? And then we added on top of it, for example, mortality. So you have 3 different variables. So let's look at this one first. For example, the really the black and the dark blue areas, those are areas that have a higher number of people who smoke, 55 to 79, that don't have access to lung cancer screening and a high mortality rates. Those are areas, right? People don't have access. Maybe we want to consider mobile units. Maybe we want to repurpose existing screening locations, while those the other areas that are the darker yellow, right? Those are areas where people have access, but we have high mortality. What's going on there? Maybe navigation, right? So different approaches based on how we bring together all of those different variables. And then we looked at rural and urban. So you can see here at the bottom left, for example, the really dark red, those are like the really urban core areas. Then you have the more suburbia that are the yellows, and then you have the small towns, and then the isolated in the gray. But the white color that you see is access. So this is how it looks at 10 miles, access to lung cancer screening. Really the real urban core areas, right? At 20 miles, you have a little bit more. At 40 miles, it's almost like I showed you a second ago. And then at 50, and then at 100. Not that we expect people to travel 100 miles for screening, but those areas don't have access. Who lives there? Who do we need to reach? How do we need to reach them, right? So all of those questions we can start answering with GIS. And the work that we've done, that specific research was used at the national level. We were so honored to be mentioned as part of the lung cancer companion brief that was provided by the President's Cancer Panel report. So you cannot really get higher than being mentioned by people that are in the White House, right? That was a great honor. But then we used the same exact data to help our ACS Mississippi team that established a social media and a billboard campaign in the state of Mississippi to increase screening rates, right? So very different approaches using the same research outcomes. So GIS can be very effective in that way. This one is a project that we published a couple of years ago that we used cluster analysis, which is a statistical analysis that allows us to identify, in this case, pockets of elevated mortality rates of colorectal cancer. And been to the Southeast Conference for Colorectal Cancer it was a few months ago, and people are still using that. So I can tell those of you that are familiar with that work, we are working on updating that, but this is another example of where we can look at trends and patterns over time of, for example, mortality and incidence rates. So one of the things that we can do very effectively with GIS is actually take text information that is provided in different ways and then bring it together, understanding that it comes in different formats and different scales from different organizations. So how do we do that? So for example, the basics, right? Cancer facts and figures from my colleagues at the American Cancer Society. We have to know which level and which geographic scale to map surveillance data, right? Then we want to understand what is the population at risk. So a lot of times, when we talked about colorectal cancer, we know that we see higher incidence rates of younger adults. So we start to look at different ages, and I'm going to show you how that can really impact how we target different communities. What is the landscape of screening? Do we really know? We've seen that there decrease in colonoscopies during COVID, for example. We saw an increase in stool tests during the same time. So how do we bring that about? And then we have those kinds of publications that there is so much to unpack here from a geographic perspective. But I'm going to note, for example, they talked about the importance of socioeconomic status. So we have different variables that we may want to bring to the discussion and add to a model or to a visualization that we have. And again, access to screening and treatment, extremely important. So when you're talking about surveillance data, you have data at the state level, then you have data at the county level. Of course, we always want to work with the most appropriate geographic level. In this case, it's going to be the county level for the most part. The same for incidence. Screening rates are available, also model-based for screening rates for colorectal cancer at the county level and even the census tract level. So we can talk about that and consume those layers as well. And here is, for example, if we're going to look at those counties that have 25,000 people or more within the age group that we are interested in. So if you're talking about 50 to 75, those would be your areas, right? That you want to target, but then 45 to 75, look at 40 to 75. If you're talking about younger adults, it really expands the geographic area that you want to look at. And I'm just looking at the Southeast region. Another thing from a GIS perspective that you want to take into consideration is, do you want to look at your a state and look at counties relative to what's happening just in your state, that is going to look very different than when you want to look at yourself relative to the region or relative to the nation, right? Your colors, where you are, may change dramatically. So you really need to take that into consideration. Then with GIS, you can overlay federally qualified health centers, CRC hospitals, the same on mortality, bring screening to the table. And then we can create those bivariate maps. Again, those dark brown areas are areas of high mortality, high incidence, and then we can add screening on top of that. So you may look at counties that have the lower screening rates in the state, right? They're in the lower part, but then they have still high mortality and high incidence. How do we target that? You can look at things at the regional level. You can look at that at the national level. That is an example of something that I would not do. That is not a good visualization. And if you want to show the data at the national level, I would look at, other ways of doing that. I wanted to bring some bad examples as well. In other cases, we were asked in Virginia, for example, to also look at the socioeconomic status. So we added poverty. And here we have social determinants of health. We have smoking, for example. So now you can see, for example, some of the counties here, right, that have high mortality rates, and then they have low screening, high smoking rate, and high percent of people that are below the poverty level. So you start to see all of those patterns emerging within states that you're working on at the regional and at the national level. And the next slide, I'm actually going to refer to Victoria. That came to me with the question that she had. And Victoria, go ahead, talk about how you use GIS.
Hey guys, so I'm Victoria. I'm a fourth year medical student at MCG. Dr. Sahar is my mother, if you missed that at the beginning of this. So I actually came to her with this idea of identifying locations for PrEP coverage in high-risk areas in Georgia after participating as a clinical volunteer at MCG's student-led equality clinic that serves the under and uninsured LGBTQ+ population of Augusta. And that's where I first found out about PrEP and the fact that Georgia is currently the fourth highest ranked state in number of new HIV diagnoses and nationally. So I came to my mother with this idea of targeting certain counties in Georgia and understanding where is kind of best to try to reduce these numbers of new HIV diagnoses. And so we investigated data from the CDC, the Census Bureau, and the Georgia Department of Public Health to identify what variables best fit to answer this question. And we landed on the number of new HIV diagnoses that you see on the left and the number of persons using PrEP as of 2021 on the right. And we compiled this data into a bivariate map, which you guys have been introduced to earlier in this presentation, which did help expose some potential target areas in Georgia. And so you can see these darker blue counties. These represent more of the urban counties in Georgia, and they have a high amount of number of new HIV diagnoses as well as a high amount of PrEP coverage. And these white dots that you can see represent a high amount of people living with HIV that we use as a proxy for infection risk across counties in Georgia. And conversely, you can see that more rural counties have a high number of HIV diagnoses, but lower PrEP coverage and use. So the idea is that we can use this map as kind of a stepping stone and present it to different organizations to try to understand what interventions we can implement in these areas to reduce number of new HIV diagnoses in these urban areas where there's a high amount of people currently using PrEP. What is the barrier? Why are we not seeing that reduction in new HIV diagnoses? And then these rural areas, taking it into consideration, the under and uninsured populations, as well as social determinants of health that would be a barrier to access. So it just kind of represents all of the things that my mom has kind of talked about so far. Yeah.
So what I would like to say about that is that, one, nothing makes me happier than working with young investigators and exposing how GIS can be used, from the beginning of their career to kind of really explore different issues in public health and challenges. But I will say that if you are in an academic setting, usually like at Augusta University, you have access to those tools, and with a little bit of guidance, you can do that. So I'm so happy that I was able to help with that. I know that I'm like a minute after. I'm going to play here a video that shows a tool that we've created. It's a colorectal cancer dashboard. It's just a minute. And this is kind of an interactive tool that we are working with the National Colorectal Cancer Roundtable to actually place on the website and make that available to all of you. You see that you have two different maps here where you can overlay data such as NCI designated centers and FQHCs over mortality rates, and you have screening rates at on the right, and you will be able to see how you can change and how the graphs at the bottom kind of change as you zoom in. But I would like to be sensitive to your time, so I can let it play for a little bit, and you can take a look at that, and I can answer any questions if there are any. But thank you. If there are no questions, I can just, it's going to end in just a few seconds. But you can see how the one on the right is a really nice layer, the race and ethnicity that we use from the Living Atlas of ESRI. And you can see that there are the colors represent different race and ethnic groups, and how dark it is. It's basically showing how dominant that group is within that specific county, and it even go into the census tract. So I will stop sharing now so you can continue. Okay, there you go.
Sure. Thank you. Yeah, that was really interesting. And so the last slide that Dr. Sahar had, I think that's going to be available to the public soon, right? Or is it already available?
It's not already available. We're working with the National Colorectal Cancer Roundtable, with the representatives of the American Cancer Society on that wonderful organization to make that available. You know, so I'm sure that they're going to communicate with all of you when that is going to be available. And I would like to note, those of you that are interested, a lot of the work that we've done with the National Cancer Roundtable and we made available, we are hopeful that that's going to be a very similar thing that we're going to implement with the National Colorectal Cancer Roundtable, and I'll be happy to put in the chat the link to some of that so you can go and explore.
Thank you. Looks like we have a question from Lorianne.
Yes, I do have a question. Thank you for your presentation. So when you're creating the categories so that you can map out the colors, do you default to the natural breaks, or do you equate it, divide it up?
No, and I'm so happy you asked that, because, you know, on my first presentation, GIS 101, that's the first thing that we do. We put like 4 different maps, and I wish I had one like that. 4 different maps, the same data, shown completely differently because you're using a different method, a different statistical method to actually create those thresholds. So I actually do not default to natural break. What you need to do is to look at the distribution of the data. So on any GIS system, and even if you take it to SAS or SP, even Excel, right, you can create a histogram and look at the distribution of the data. In public health, I will say, and the amount of data that you usually have, you know, a lot of the data that we have is you will be able to look at that pretty well with quantiles if you have to default to something. And usually public health and epidemiologists work a lot with that kind of a statistical way looking at the data, right? We really like that. So if I default to anything, it's usually quantiles, but we do look at the distribution of the data, because you do have natural breaks. Yeah, for the most part, you have you can use standard deviations, right? To review the data. You can just do continuous, but yeah, please don't default to natural breaks whenever you have public health data.
Thank you.
Thank you. Does anybody else have any questions at this time for either Victoria or Liora? If not, we can go ahead and get started on the next one. So thank you guys for putting that together. That was super interesting. I especially liked Victoria's map that showed Dougherty County was in dark blue. That's where I'm at right now. And it also showed Savannah and Atlanta. And so that really just made it very clear where these hotspots are. So really a great way of identifying these things, target interventions at. So our next, and if anybody has questions for our previous presenters, we'll have some time after our case presenters as well. So if y'all are around, you guys can stick around and we can have any further questions. But for our next section, we're going to have case presenters. So every echo session, we also have presentations from the field, and they're able to tell us how things are going from their perspective. So typically we have had presenters from Georgia. This time we're fortunate to actually have somebody from a different state so we can actually see how things are going with their program in Missouri. And so this is going to be Alicia, Nuha, and Shoei from Missouri University. They're a grantee for the CDC, just like we are. And so they're going to talk about their program, Missouri Partnerships to Increase Colorectal Cancer Screening. So you guys can share your screen.
All right, so hi everyone. Thank you so much for having us today and that lovely introduction. I am so excited to be presenting our successes and challenges in rural Missouri communities when it comes to CRC screening. So let's talk about Missouri first. We have this saying that we're known for being the show me state. So that's an expression that reflects our need for proof. So here you go, a little bit of something about ourselves. Our overall CRC screening rate is at 64%. About a third or 34% of our population lives in rural areas, which as you can see equates to 99 out of our 115 counties being rural. And some quick highlights and explanations about the CRCCP grant that we're a part of is that it's a 5-year cycle, which is new for Missouri as it just started during everybody's favorite year, 2020. And as you can see nationally, other award recipients include health departments, tribal organizations, and universities, which is where we come in, the University of Missouri. And the grant focuses on integrating EBIs, or evidence-based interventions, which listed below, we look at integrating into a health system's workflow. So we learn where opportunities are to merge in those patient reminders, provider reminders, et cetera, to ultimately increase CRC screening rates. And now that you understand what the grant entails, it partnered with us here at the University of Missouri, and then boom, MPICS was born. So a little background about our current partners include our collaboration with 7 health systems, that's totaling 29 clinics, with the majority of them being in rural counties, and a few demographics of our patient populations noted below. So as of now, 84% being white, a little over a quarter being uninsured, and 7% being non-English speakers. And to give you some context on where we started, we've illustrated for each county the number of clinics on the map. So as you can see, there's a spectrum from 19% at the lowest to 51% being the highest baseline CRC screening rates. And then lastly, here's a timeline to illustrate when our partners onboarded with us and how our newest partners joined us just last year. Okay, so now that you know more about us, I just wanted to echo what many of us know as challenges in rural health. So the barriers such as transportation, access, and resources such as distance to procedure centers and reluctance are consistent things that patients face. Now, for those working in healthcare, the hierarchy structure doesn't always communicate information to the frontline staff. There's unfortunate staff shortages, and the EHR changes also contribute to these challenges. And one more thing to consider is that cultural mentality that seems to be prevalent in rural communities. So my grandpa didn't do something, my dad didn't, so why should I? And that can provide some hindrance when it comes to prevention and screening overall. And I say all of that to begin our first case study working with Joplin's Free Community Clinic. In addition to those challenges mentioned in the last slide, Joplin also had no software to conveniently pull specific data. So that's something that other federally qualified health centers have. The clinicians who are paid are few, and there's a lot of dependency on volunteers, which can affect the continuity of care and training. And lastly, they had no prior experience doing CRC screening, having a policy or protocol, as well as the patient population all being uninsured. So what did we do? We took the time to understand their EHR logistics, how and where they documented, and what data they could or could not pull or track. Since this was going to be the first time that they were going to implement CRC screening and data input, and we just weren't sure what the data they pulled would actually look like, we created a simple manual Excel form to track that CRC screening for their patients. So that included variables such as who's receiving the FIT kits, the results, the colonoscopies that are scheduled, and the colonoscopy reports. And then secondly, we took the time to understand the clinician's workflow. So this was imperative when integrating those EBIs. Understanding the role of each staff member, assigning a clinic champion, and where is it feasible and convenient for patient reminders, provider reminders, et cetera, to merge into their everyday practice, or rather, do we focus more on efforts for reducing patient barriers? And providing staff and volunteers CRC screening education by creating protocols and how-to guides on what and where to document, would aim at keeping documentation consistent and reducing those input errors since volunteers change and come and go. And then lastly, we did some research and connected the clinic with a procedure center nearby who could perform colonoscopies at no cost if patients qualified. So this is huge. This is a huge opportunity to reduce the cost barrier for uninsured patients. And here's what the data shows so far. So for ages 45 to 75, Joplin's baseline rate was 0% since they had not previously conducted or tracked CRC screening. And then after discussion and efforts from the previous slide, they rose to 15% in Q1 and are recently at 14% in Q2. So in the 6-month span, it's just exciting to see their progress and room for growth. Our second case study is going to be an umbrella of patient needs that we encountered in many of our clinics. So we got some feedback from staff that men as a group were not getting screened. Then there were some variations in patients' health literacy, the consistent transportation barriers that rural patients face, and the language challenges. And then lastly, the common insurance and cost dilemmas patients need to consider when getting screened. So some solutions that I'll share with you include creating targeted infographics for men, creating our own version of fit instructions to combat health literacy, researching Uber Health and Angel Flight to provide transportation options, calling all health and procedure centers that service patients in these clinics to understand their costs and qualifications for financial assistance, as well as providing resources in different languages. So here's some examples. Here's an example of our safety net and our transportation resources. So the safety net provides a breakdown of costs at each procedure center nearby, as well as including transportation options and distance breakdowns that I just previously mentioned. And here are the targeted infographics for men that began with the truck theme, which gradually evolved to fishing and was recently incorporated into a Father's Day social media post and a postcard with the goal to reach and make this relatable to men in rural areas. And to assist with patients not understanding or being intimidated with their fit kit instructions, we created fit instructions with more illustrations and provided it in other languages if needed. So the key takeaways that we found that helped our systems can be divided into 2 categories: communication and tailoring data. So with communication, we meet clinics where they are, we listen and promptly reply, and this helps build rapport and trust. And once those COVID restrictions were lifted, we started meeting clinics in person, and we found that to be immensely impactful. We did this monthly or quarterly. So as many as you know, not all clinics have the same infrastructure and workflow, so we accommodate them where they are. And then I think it's good to note that we as practice facilitators, we all have clinical backgrounds, so we can empathize and understand a clinic's workflow and speak their language. And then when it comes to tailoring data and education, we provide resources at a system, patient, and clinician level. So for example, the safety net that I shared was for the system. The men infographic was for the patient, and the data infographics are for clinician. Providing multimedia options to post on a health system, social media is also an opportunity to merge CRC screening messages with themes and seasons that can reach patients. And then lastly, creating those data infographics for clinicians also allows us to see trends and identify challenges sooner. So here's an example of that. Each clinic within a health system has data that we analyze and present quarterly. I will note that for CDC, they only require us to do this annually, but we found that doing it quarterly is beneficial in keeping clinics engaged and informed on their progresses. And as mentioned, identify those challenges sooner rather than later. Here's another example of tailoring clinician data by giving them a feasible goal on what is reflected on their quarterly reports that we create. And then on a patient level, here's an example of a social media post, as well as a simple patient reminder that can be placed in the exam room. So the impact thus far, if we average for our clinics 3 data points, and that's not including our newest partners, put us at an almost 10% increase from the time that we started through last year. And then as we look ahead at the big picture, we envision like innovations for rural counties that can include usage of drones for clinic supplies or pharmacy needs, and collaborating with pre-existing programs for the breast, cervical, and prostate, which are already similarly doing what we are. But if we can combine efforts, we can simultaneously reach patients and improve all screenings. So thank you so much for your attention and allowing us to share our journey with you. I leave our email and our website, and we're always happy to share resources too. Thank you.
Thank you, Alicia. That was a super informative presentation. I think probably we have some of the similar barriers here. We actually have a poll that we're going to use to try to query our audience. Most of the audience is from Georgia, but we also have people from all over the country on this call right now, and so maybe we'll be able to get a better understanding of what barriers and issues that people from all over the country have been facing. So I think Brenda or Chris, if y'all have access to the poll, if you guys can go ahead and put that up. Oh, sorry. So the first question is actually going to be about our GIS, and so we'll make sure we incorporate that as well. And so the first question is, how could GIS be used to help increase CRC screening in your region? So this is just a short answer question. I think you can just put really at any comment that you saw as far as utility for your region, your clinic, your health system.
By the way, I would love if people can comment on what is a gap in their perspective. So maybe, Kush, if you wouldn't mind sharing that with me after that, we can see how we can, at the national level as well, provide data and tools and share it with people.
Yeah, that'd be really helpful. So if you guys can just put in maybe areas of interest that you guys might have, or gaps that you may have seen that maybe you guys can help, how we can use GIS to solve any problems that that we have facing in our regions and in your individual regions. I'm gonna give another minute to do that, about 30 seconds to a minute. So if y'all can, we can get some good feedback. I think that'd be really helpful. All right, guys, so we can go ahead and close the poll, and we can see what answers we have. Lorianne, or not Lorianne, sorry, Brenda, I think, if you can do that. If you can go to the next, if you can close this question and go to the next one. Here we go. And then the next question.
That's the only pool question.
Oh, okay. We didn't use the other one. Oh, okay. All right, that's all right. So actually, so maybe we can use this as an opportunity. So the other question that we were going to have was going to be about barriers that you guys have faced, and similar challenges that we've had to Missouri. And so that was the other kind of discussion point that we were going to have to see what similar shared barriers we have. So if we can, I guess I think Lorianne has her answer raised. What, Lorianne, go ahead.
I was raising my hand for a question.
Okay, you can ask your question. That's good.
Okay, my question was for Alicia. Since you had that one clinic that you started with who had never tracked the CRC screening rate, so I'm sure there were a lot of challenges with that. My question is, what were the advantages of that? Because you're coming into a clinic that doesn't have set, rules or anything, guidelines for they follow, maybe a workflow. So what are the advantages of that?
Hi, yeah, that's a great question. So they definitely had the big thing was like they had the desire to want to do this. They had partnering communities, clinics too, that were doing well. And then the advantage was, since it's such a vulnerable population, and if they had patients coming in that were just symptomatic with GI symptoms, what more could they do at that point? They didn't have a lot of resources to do colonoscopies if needed, or an endoscopy. A lot of the hospitals nearby, it's just more complex to do an uninsured patient anyway. So I would say in terms of advantages, it just provided such a great door of resources for those patients, but also for them to kind of see their progress and then just kind of keep them with the volunteers and the physicians that were just kind of not very consistent. It just proves to show if you have a good foundation, like things can possibly be sustainable. So that's where we are. We're only a year in with them, not a year in. So I hope that answers your question.
Okay. I think that willingness is a big thing, because if they really want to do it, hopefully they'll find a way to follow through. My other question has to do with the data, getting the data from the different clinics. Do you have any challenges getting the data quarterly as you wanted? So how do you collect it? Do you actually go to the clinic and get the data from it, or there's somebody who sends that data over to you?
That's also a really good question. So we have a REDCap portal, and I'm not sure if you're familiar with REDCap, but that definitely allows us to put all of our questions that we would need, or Excel template for upload data. And we would send that link via email to the corresponding clinics that we would need them from. So that's kind of like the quick and easy answer. Now, has it been complicated at times, or maybe not as user-friendly on their end? Yes, that's been a challenge at times. But what we have found is, since we're meeting with them quarterly or monthly anyway, that's a great opportunity for us to just kind of educate them and show them and just understand, hey, what are you working with? What are you seeing? How can we help you kind of identify those gaps? And so that every time now that we're asking for these uploads, it's really easy for them and really easy for them to understand. For the ones that are onboarding, for sure, definitely just, a little intimidating, a little confusing at first, but our REDCap portal links have made it easy for them to upload.
Okay, and that quarterly, do you collect all the variables that CDC asks for annually, or do you just focus on the information you want to, for the quarter?
New Hawker on, do you want to confirm? I believe we do what is annually required.
Okay.
So yeah, we're just doing it more times than not because of the quarterly that we're requesting. Yeah.
Okay, thank you so much.
Yeah, thanks.
Thank you. And so we have a couple of comments in the chat, and so we have a comment from Nikki that's saying that love to see the CRC prevalence layered with the SDOH, such as food deserts or poverty levels or educational attainment. And then there was a comment saying from Hillary saying, agree with Nikki on both inability to see results plus the SDOH overlay, especially with this transportation time to GI appointments. So Dr. Sahar, do you have any comments on that?
So yeah, so the first one I answered, Nikki, it's really important for us to understand the different social determinants of health. I can tell you, for example, that last year as we were working on the atlas. We're working on the atlas for the lung cancer for several years, and then we were sitting in the biomarker summit, and there was so much new research and new social determinants of health that came out from recent research. So it's really important for us to get that kind of information to make sure that we include that in the dashboard. The other one is time to GI appointments. That requires quite an analysis on our end. I know that we've been talking about access to screening and access to treatment internally. So I cannot promise you anything, but this is something that is on our radar, but I cannot commit to that layer. Sorry, but it's something that we are talking about.
Sure. Makes sense. Yeah, it seems like there'd be a lot of data that we probably may not have easy access to.
The problem is, when you're talking about GIs, even getting a list of all GIs in the United States, it's not as easy to attain, actually. Sure. So a lot of times we work with CMS data to get locations, working with the NPI. So we use that for other. I can tell you that we do access to all kinds. Including I actually looked at access to GIs. And the way that we sometimes approach that is that instead of providing, for example, access to point locations, because we know that some of the NPI data, because it's self-reported data, has some error associated with that. Sometimes what we end up doing is, for example, heat maps. So we're not committing to each and every point, but you get a really good idea where there is no access and things like that. So we can do easily things like that, rather than the actual, time to each and every one, which we can also do. It's just that we have other priorities right now, and that is not a project that is on my docket right now, but it's not the first time that I've been asked that. I will say that. So eventually, when enough people ask for that, it will come, higher in the priority.
Great. Yeah, thank you. I think Dr. Hotz has a question. Dr. Hotz?
You're on mute, Jim.
That's a great presentation. And, we know it takes a village to raise a child, but it takes a health system to control cancer, colorectal cancer especially. And those of us in the health center world, if we think of this as kind of a war on cancer, we're kind of the Marines who's established a beachhead of an underserved population. But we can't get our job done unless we have the full battle group there. The aircraft carrier that really carries all the power are the health systems. You are kind of like the intelligence officers who can tell us where we need to strike, and you've got great data to show that. But unless we can connect the field, with the battle group, it's difficult. Do you have any examples in which health systems actually use this data, or any examples of how we could do that? I know ACS has great convening power, and I've seen a couple they've done this thing called links to care, where you actually try to bring it all together. Any examples where this is being used? Because I think it's great information, and those of us in the field can realize we've got those hotspots around us, but getting the whole health system engaged is a challenge. Any thoughts?
Dr. Sahar? I think, was that for Dr. Sahar?
Addressed to me. I thought that you were addressing some of the representatives of some health systems.
No, I was addressing you and American Cancer Society, how you use this.
Okay, yeah. Sorry. So my team is really, we know each other for a while. My team is focused really on the geospatial and, the analysis. What we do is we work and collaborate across the organization with different individuals and groups. Such as the National Colorectal Cancer and others. So I can tell you that, for example, when we all attended the Georgia Colorectal Cancer Roundtable, we actually talked to the health systems that were there, and we were asking, how can we collaborate? Because you guys hold the data that if we get that data, we can actually paint the real picture of what's going on out there, and then work together to actually, put some things in action, right? So I was there with Dr. Smith, Bob Smith, that you know really well. And I think that there needs to be some kind of a collaborative approach here. From my perspective, I cannot talk for Links to Care and other, initiatives of the American Cancer Society. I'm not, leading those, so I don't want to comment on all of those. But I can tell you that I hope that, for example, the annual meeting for the National Colorectal Cancer Roundtable, where we're going to have quite a lot of representation, both from American Cancer and other, state and then health systems together. Maybe that will be a great opportunity to start bringing all of those different, different groups together and start talking about collaboration. From my perspective, give me data. We talk to the health systems and ask questions such as, can you share with us screening rates across the state of Georgia, right? We want to, because we have model-based data, we have other data, we have birth data, right? But do we have real data from the field, right? What is actually happening in different parts of, either the state or the country? And from my perspective, bring it on. I would be happy to go back to, my colleagues at American Cancer and talk about that. But again, I cannot speak for them. But meetings like the one that is coming up next month, I believe, will be a great place to bring all of those together face to face. And that in person, magic happens, right? So and
that's one of the points I'd like to make. We don't have a health system. We don't really have a way, but roundtables are a de facto mechanism of creating a health system that can address these things. So encouraging people to participate in our state roundtable, and those of us who'll be participating in the national one. I just wanted to make certain people aware that, you got to get out of your house and get involved in things like roundtables or your state cancer plans to really make a difference, because now no one group can really, raise the child. It takes the village. It takes people creating systems to really address these issues.
And Jim, can I add to, is that okay if I add to that? So
yes.
This year I had the pleasure of being at the Georgia and then the Southeast and now the National. And it was really interesting. And I can tell you that so many collaborations and so many, requests and comments came out of each and every one of those. And after the Southeast, that like, for example, the pockets of elevated mortality rate, it was a research that we've done with my colleagues at the American Cancer Society. After we've seen, so many people coming and talking to us about that at the Southeastern Conference, we're 2 months after, and we've already initiated, my team has already initiated that specific work. So, sometimes it's easier than other ones. And again, I cannot speak for the larger organizations and how they work, and I'm not going there, but you're so correct. We need to have people showing up and talking and sharing, right? Sharing their problems, sharing their gaps, sharing their data as well, to give us the opportunity to provide those different tools and do the research and whatnot. Do I make sense?
Yeah, good. Thank you.
Yeah, thank you. That made a lot of sense. And so, all right, so we're getting close to the end here. Just from our hub team, Chris, are there any more questions from the chat that you saw, or that you had any comments? If not, I can ask Lorianne, do you have any comments to add?
Not any comments, but I like to, you can go over the poll, because I'm interested to see that people think.
Sure.
My grandfather.
Yeah, I didn't see the results. Brenda, are the results there?
I am sharing the results. I don't know if you can see it.
Can everybody see the results? I can't.
Yeah, it's on the screen, Kush.
It's on the screen. Okay.
Yeah. I don't know whether you can see it or not.
I cannot see it. Maybe Manuel, you can kind of go over those results, because I can't see them on my screen. So, oh, there it is. Yep.
Okay.
All right. So this was the poll question number 2. So it looks like there was this. The one I'm seeing right now is the. Oh, let's see. 1 second. Yeah, maybe you can run through them. I don't see the results, Manuel.
Okay, so do you see the number 1 question based on Missouri's presentation? What challenges do you face most with colorectal cancer screening? So you have multiple choice questions, and we have responses on that. Transportation to appointments, 38%, that's a problem. Health centers, far or few, that also 25%, 1/4 of the respondents said this is a problem. Communication from administration to clinical staff, that's 38%. Staff turnover, 38%. New EHR upgrades, still 13%, not the big number. And my grandpa don't, my dad don't, so why should I? That was a question that, and 50% responded that one, that's a problem. So this is respond to the question number 1. My interpretation is that there are issues with the transportation, communication, and also staff turnover. This came as a big word, but the mainly patient's perspective, what we learned that they sometimes is, my parents, my grandparents did not, screen, why should I? So that was another big challenge. So there are 2 front, issues are there. So this is the only one I see, Brenda. Is there any other result?
Let me share.
I think we're getting close on time here. So maybe in the next presentation, we can kind of go through some of those because it'll still be relevant to us. And we'll definitely share them with Dr. Sahar once we are able to access those. But so thank you for joining, everybody, and thank you for presenting for us. So both our expert presenter and our case presenter, that was really super informative, and I learned a lot for sure. And it was also interesting to hear from another state to see how they're doing things there. Money Rule, you can go ahead and take over the rest. Talk about the CME and the next.
Well, thank you, Dr. Desai, for your running the program and taking us to here. I wanted to thank you both presenter, Dr. Sahar, and the University of Missouri group, Alicia, for presenting wonderful informative information, which is very productive for us to take it, lesson learned from you. So one thing that I wanted to tell you that we, in addition to participants for this session, we also provide a benefit to all participants for continuous education certification. So if you want to claim your CME or CNE, please go to the chat section and follow the link there, or scan the QR code to receive your certificate. There are a few announcements that I wanted to say that we have been, as the beginning, Dr. Desai mentioned that this is our 17th session. So this session will be continuing as long as we have the funding from the CDC. So we'll be looking for volunteers to present case studies for these upcoming sessions. If anyone has any particular case and we would like to present, please email to us at au_crcscreening@augusta.edu. Our next session would be Wednesday, December 6th, 2023, first Wednesday of the month. We will share our flyer with you for our next session within 2 weeks. Thank you everyone for attending. We will see you on next session. And at this time, those who are attending from the clinics, we want to thank you and goodbye. We'll see you again. And only the hub team will remain. Rest of them you can sign up. Thank you everyone. Have a good weekend. Good day.